On the 2nd of July, our previous health minister in the United Kingdom made a statement that I want to play for you here. And the reason I brought it up is because, in my view, one of the issues we face in the pandemic or beyond the pandemic is that of rebuilding trust. If there is no acknowledgement for any mistakes or any problems during the pandemic, how can you expect people to trust you? And this is essentially what I think has happened here. So this clip was on X Twitter, and it was taken from the 2nd of July with Matt Hancock, the previous health minister who was in the Conservative government at the time when COVID-19 hit. Listen to what he has to say now and reflect on the implications.
Is that vaccination of a condition of deployment has a lower impact than we had feared before bringing it in. And therefore, the balancing item, the only argument you can make against it, the only moral argument in my view, is weaker than we thought at the time. The logical case in favour of vaccination of a condition of deployment for people in caring professions is absolutely categorical, stronger than when I brought that policy in, and is a deeply ethical and moral policy.
Thank you, Mr. Payton.
Yes, so
is the vaccination.
You can see the point that I'm making here is that I could understand his perspective in 2021 because the science they weren't sure about, everybody was afraid. They had all of these vaccines that they were told were 95% effective, not recognizing they were talking about relative risk reduction, not absolute risk reduction. They were told that it would block the transmission of the disease. And so, in effect, for them who were informed, I think flawed information, they thought this made perfect sense. And so, at the time, you can, to some degree, understand the mistake. However, at this point in 2025, my view is very simple. Anyone who had that kind of position was able to influence the way that the healthcare system worked and operated, who was in a position to institute mandates. If at this point there is no apology, no recognition or acknowledgement of error, those people should not be put in that kind of position again. That's my personal view, because what it indicates is a lack of an ability to reframe or to learn from what had happened. Many people don't understand why I keep on harping on about COVID-19 and the COVID narrative. And largely it's because if we don't address this now, it's likely to happen again. So if in the next few months there is, for some random reason, another virus that came out, the same people who put in the mandates will do it again. And the next time they'll try and get it better. But it represents a fundamental lack of understanding about the science. And as I said, I could probably understand the error in 2021 when all of the papers were saying the same thing and you're hearing everything on the news saying the same thing. But once it was clear that people who were vaccinated were getting recurring infections, that should have been a red flag. You have to remember, specifically in the context of healthcare workers, they had faced the pandemic, often without PPE at the time. There was no masking, and they survived. So by the time you reached January or February 2021, almost every frontline healthcare worker would have been exposed to the virus. There were a number of people who had to shield because they were high risk. And I still maintain that at the time where there was limited understanding, it would have been reasonable and you wouldn't have had to mandate them. They probably would have been very happy to take a vaccine at that point. And so there would have been no need or should have been no need for mandates. If there were healthcare workers who were still concerned, even after exposure, then fine, they could be given the opportunity. But fundamentally, there was a flaw in the understanding of the science. And just to highlight a few points here, because this was reviewed in 2023, and it was looking at vaccine mandates for healthcare workers beyond COVID-19. And when you look at the abstract here, and this was published in 2023, and it was done by the Oxford Centre for Practical Ethics. And they were looking from an ethical point of view in terms of what was done. I've highlighted here in the abstract. Our conclusion is that given current evidence, those ethical criteria justify mandates for influenza vaccination, but not COVID-19 vaccination for healthcare workers. As I said, the premise here is that they have acknowledged in 2023 that ethically they shouldn't have mandated COVID-19 vaccines for healthcare workers. And some people perceive this more of just ethics. And why am I talking about the ethical point of view? My perspective here is that it is way beyond ethics when there is poor understanding of the science. As I said before, when you actually understand the mechanism of severe COVID-19, and this is what you must ask people. If someone is still saying mandates, and just ask them if they understand why someone gets severe COVID-19. And what you will realize is that they don't know. And so their decision is based on fear rather than science. They're just saying, well, I'm afraid you may pass it on to someone else, not taking into consideration just how effective natural immunity is. Because what people don't quite understand is that even when the body finds the way to develop immunity against SARS-CoV-2, what was very interesting when they looked at the natural immune profile and what was targeted by the immune system, it didn't go after the spike protein. Only 20% of the epitopes were targeting the spike protein. It primarily targeted the nuclear capsid and the ORF proteins, as well as the membrane and envelope proteins of the virus. So it targeted multiple areas. And the fact that it targeted what we call ORF, open reading frame proteins, indicated that this was primarily cell-mediated immunity, because in effect, these proteins are only found when the virus starts to replicate. So you won't see it in the bloodstream. So antibodies wouldn't be very useful. So what it indicates is that the immune system targeted infected cells via cell-mediated immunity. That's very important because it therefore means that focusing on antibody production is unlikely to give you the kind of response and protection that is required. And this is why sometimes they would find somebody who had, say, a mild episode of COVID. And when you do their serum levels for antibodies, it's sometimes non existent or very low. And that's because the primary way that the body deals with the infection is cell-mediated immunity, not humoral or antibody-mediated immunity. Additionally, another paper had come up, and this had looked at the response, the mucosal response, comparing antibodies in the mucosal system, systemic and mucosal IgA responses induced in response to SARS-CoV-2 mRNA vaccination. I don't have all my slides here, so I'll just explain the simple premise, is that immunity is is dependent on where infection is. So, say for instance, your skin is an immune organ. The fact that you have a layer that doesn't allow penetration of bacteria or viruses is part of an immune system in your skin. And the kind of immunity that the skin provides is different from what would happen in your bloodstream. In the same way, your respiratory lining is also another barrier, and that's mucosal immunity. And the kind of immune responses that are produced there are different from what happens if a virus or a bacteria gets into the bloodstream. It is the equivalent of hiring more soldiers or security in a prison, or well, imagine you are securing Fort Knox. And what you do is you get a lot of security inside it, but you take down all of the barriers and the security outside, hoping that the large number of security walking around will be able to protect it from being attacked. That's so in effect, systemic immunity is later on. It's like a second line of defense. The first line of defense is mucosal immunity. That means when the virus tries to break through the mucosal lining. And what they found when they looked at the research, and you can see here, and this is looking at, they said, analysis of anti-spike and anti-RBD antibodies in saliva from people who had COVID-19 vaccines. And so they're looking at a period of time, baseline 2 to 4 weeks, 3 months, and then 2 to 4 weeks post the second dose. And you can see here, IgG is talking about serum response in the bloodstream. And you can see there is a response here, first dose, and then an increase in the second dose. But when you looked at the IgA response, there was a relatively weak response, and IgA is what is in the in the saliva, in the mucus, and this one operates differently from IgG. A weak response here drops right down within 3 months, and even after the second dose, it's still a very weak IgA response. And this is the characteristic why it is that so many people, even though they're vaccinated, still get infections. Immunity, protection level that's on the inside, the lining of the upper airways going down into the lungs, is critical to be able to understand how the virus is able to get into the bloodstream. Where we have a problem here is that science has taken a backseat. Politics, the need for the scientific and sometimes medical community to be right has taken the front seat, because even at this point, there are no apologies, there's no contrition. This is just, yep, if I had to do it again, I would do exactly the same thing. That's the big worry that we have. And if you've just joined me here, I want you to again listen. And this was Matt Hancock, who was the past health minister during the COVID pandemic. And he was responsible for the institution of vaccine mandates to healthcare workers for COVID vaccines. And this is what he had to say on the 2nd of July, 2025, when he was reflecting on the decisions that were made at that time. Here is what he said.
Is that vaccination of a condition of deployment has a lower impact than we had feared before bringing it in. And therefore, the balancing item, the only argument you can make against it, the only moral argument, in my view, is weaker than we thought at the time. The logical case in favour of vaccination of a condition of deployment for people in caring professions is absolutely categorical, stronger than when I brought that policy in, and is a deeply ethical and moral policy.
Thank you, Mr. Payton.
So as you can see, only a doubling down. That's the reality of what we're facing now. We have some big challenges ahead because, as anyone will know, when I speak about spike protein mediated autoimmune responses, my concern going forward is that as the virus continues to circulate, it will continue to trigger all kinds of unusual immune responses in people who are infected. Basically, based on the paper that we're working on now, the time frame is not hours to days. It's, if anything, weeks to months after an infection, based on a cell-mediated autoimmune response. This is exceptionally serious. And what it means is that if we have leadership that is unable to go back to the science, address the issues, then we are left with a situation where not only is there no apology for what happened in the past, not only is there the concern that it will be done again if the opportunity arose, but there is no opportunity to mitigate and address the health-related impacts from ongoing circulation of the virus, which may appear to be mild, but is causing serious medium-term disease across the population. If you look carefully, all your hospitals are still going to be full, but they're not full of severe COVID-19. They're full of everything else. We have some huge challenges ahead, and let's hope that the science can get back to the front. Have a great evening.